Hi, everyone. I'm Sakshi. I'm one of the PGY2 residents at Beth Israel, joined by Dr. Jason Matos, one of our cardiology attendings here, and we're going to be talking about bradycardia. So I'll start by sharing the objectives of today's talk. So one, we're going to review the cardiac conduction system. Two, define the PR interval. Three, review a schema for thinking about bradycardia. Four, identify EKG findings typical of different heart blocks and bradycardias. Five, discuss the mechanisms and causes of common bradycardias. And six, a brief review of the treatment of unstable bradycardia. So I'll start by talking about the cardiac conduction system. So the conduction begins in our sinoatrial node, and then we'll have a wave of conduction that essentially will travel through your atrial muscle and go to your atrioventricular or your AV node. This conduction then continues to travel through your bundle of His to your left and right bundle branches, and then throughout your ventricles. And then what you will see in today's talk is there can be delays or blocks in the conduction anywhere throughout this system.
Each of these has their kind of own intrinsic, almost like pacing rate. Like, so the sinoatrial node goes around 60 or 80 beats a minute, and the AV node, if it was left to its own devices, would go 40 to 60 beats a minute, bundle of His around 40 beats a minute. So it can kind of help us figure out where a rhythm is coming from based on what the heart rate is at times.
Okay. So the next thing I wanted to talk about is the PR interval. And when I think about the PR interval, I interpret it as the time it takes depolarization to spread from our SA node to the ventricular muscle. When I'm looking at an EKG, what I do is I look at the beginning of the P wave, like it's highlighted here, to the beginning of our QRS. And that span is called the PR interval. Typically, you want this to be less than 200 milliseconds or less than 5 small boxes. So, what is a bradycardia? So, this is a heart rate that's less than 60. A heart blocker is a delay or a block in conduction. And then the framework that I like to use when I think about bradycardias are the location of where this delay or block is happening. I have an EKG here. Why don't you all pause your video, take a second to think what you interpret of this rhythm, and then we can go through it together. So this rhythm is sinus bradycardia. It's a narrow, complex, regular rhythm, which meets the sinus criteria that you've discussed in prior videos. And the heart rate's around 35. Our intervals look good. So I would call this sinus bradycardia. One interesting finding I wanted to share was that there's a U wave, so a wave after a T wave here, and that can be something that you can see in your precordial leads with sinus bradycardia. I also wanted to do a review of what sinus bradycardia is. So on our EKG again, it's sinus rhythm, a heart rate less than 60. And you're going to have essentially decreased sinus node activity, which is resulting in this rhythm. Common causes, so medications like beta blockers, calcium channel blockers, digoxin, amiodarone, opioids are just a few of the many medications that can lead to this. Increased vagal tone, so athletes you'll see sometimes have sinus bradycardia when you're sleeping, hypothyroidism, anorexia, sinus node dysfunction, myocarditis.
Just to go back to that list, so the U wave is true. You can see in bradycardia. Sometimes it's more amplified in settings of hypokalemia. Um, I would agree with this entire list. The other one that you see, especially this time of year, can be hypothermia,
Okay.
can be another cause. And then sinus node dysfunction, it's kind of an umbrella term, but oftentimes in patients who have degenerated sinus or AV nodes, which we'll talk about in a second, whether it be just general scarring of the conduction system, sometimes from infiltrative diseases, but frankly, more often just from advanced age and degeneration.
Okay, so this is our next EKG. Why don't you stop your video for a second and try to interpret this rhythm? So this is normal sinus rhythm with first degree AV delay. What we can see here again is our heart rate is around 80. It's a narrow, complex, regular rhythm that meets sinus criteria. The thing that's interesting is when we're looking at our interval, specifically the PR interval, This is around 260 milliseconds. And if you remember, we said a normal PR interval should be less than 200. And when you see this, this is first degree AV delay. So to highlight what first degree AV delay is, it's again that PR interval greater than 200. And essentially, you're having a delay in conduction from your SA node to your ventricle. Common causes of this can be medications, similar to discussed in the previous slide, like the beta blockers, calcium channel blockers, digoxin, amiodarone, opioids, vagal tone again, age-related disease, infiltrative disease. But often this is not a clinically significant finding. It's something we'll see incidentally on EKGs, but these patients, in my experience, are not usually symptomatic.
Yeah, I would say absolutely right, and everything the reinterpretation of ZCG is correct. It's fun, you talk about the vagal tone here. I The one thing that I would just keep an eye out for is when you have discordance between the heart rate and the PR interval. What do I mean by that? When you think about high vagal tone and a long PR interval, you think about that concurrently with sinus bradycardia. So when you have discordance, so you actually have normal sinus rhythm or almost borderline sinus tachycardia with an AV delay, it's not necessarily pathologic, but it should raise your eyebrows at the possibility of something pathologic, like is this person's status post a TAVR? Could they have infiltrative disease? Could they be on some sort of drug that's specifically impacting the AV node, like something like digoxin? So that discordance between the heart rate seems fine, but then the AV delay is present may make it slightly more possibility that there's pathology here.
Okay, so this is our next EKG here. You guys can pause your screen again for a moment. So this is second degree Mobitz 1, also called Wenckebach. So when I'm looking at this EKG, one of the interesting things that I see here is that you have like P, QRS, P, QRS, but then this P wave is not followed by a QRS complex. Whenever I see that happen, the things that I look at next are my PR intervals. Um, and you can one of the tricks that I use is I look at the PR interval before the drop beat and then after. And here you can see that the PR interval before the drop beat is longer than the PR interval after. And that to me indicates that there's PR prolongation prior to this drop beat. And that essentially is what is unique about second degree Mobitz 1. It's progressive lengthening of our PR interval prior to a non-conducted P wave. So this is often like an AV node issue, I like to think about it. Your AV node essentially gets progressively fatigued until then you eventually drop a beat. And causes, again, are the similar medications that I've mentioned before. Vagal tone, inferior MI. So if there's reversible ischemia, not infarct, also can see that. And then myocarditis. And then this is not often always significant clinically. Sometimes it may be, but it's, to my understanding, a bit more of like a benign finding.
Yeah, no, I agree with all this. This is just a characteristic of the AV node, like exactly what you're putting in the location section here. The AV node is sort of this like very robust, resilient structure where conduction can be maintained despite a substantial prolongation of that conduction. The conduction can maintain without completely failing. And traditionally, a, times the AV node is perturbed, whether it be in medications or for an inferior MI or inflammation, the likelihood of it returning back to a normal function is higher than what you'll describe later on.
Got it. Okay. So this is the next EKG. Again, if you guys want to pause your video, try to figure out what this rhythm is. Okay. So this is second degree Mobitz 2. Again here, like our last EKG, we see PQRS, PQRS, and then we do see a drop P wave here. Now, like I had said, we're going to look at that PR interval before and after a drop beat. And to me, these look pretty similar. And that's what makes up second degree Mobitz 2. So our EKG findings here are intermittent non-conducted P waves, but there isn't a progressive prolongation of the PR interval. And to my understanding, this is structural conduction failure below the AV node, common causes being an anterior MI with a septal infarct, idiopathic fibrosis, inflammatory conditions like rheumatic fever, autoimmune things like lupus, infiltrative conditions, meaning amyloid, sarcoid, and then again, those medications we've been discussing. To, this is more likely associated with hemodynamic instability, and this has a risk of progressing to complete heart block.
Yeah, exactly. I mean, basically, it's that the absence of that prolongation is a hallmark of the AV node because the AV node's so like robust and resilient. You get this prolongation before the failure of conduction takes place. And so if you're having drop beats without that prolongation, then the problem must not be in that resilient robust structure. It must be at a different level. And the only other level to the AV node is must be below that structure. And so that's the His conduction or below. Now, the anterior MI, that's because a very proximal LAD infarction supplies the first septal perforator. And the first septal perforator is what supplies the bottom of the His bundle and the right bundle branch. So heart block after a big LAD infarction is a very high risk finding, and heart block after an LAD infarct is a very poor marker. And the classic, very morbid teaching is that we don't see a lot of these in the hospital because these are patients that are unfortunately not making it to the hospital versus the IMIs that infarct their PDA at the level of the AV node are not are making it to the hospital. So we see those heart blocks and Mobit and Wenckebach events, and then we're able to revascularize them and they recover.
Got it. Okay. Our next EKG, again, if you all want to take a pause, try to figure out what this rhythm is. Okay. So this is 2-to-1 AV block. So what I'll point out interestingly here, so these are the P waves that are being dropped, and every other P wave is being dropped. And that's what makes up 2-to-1 AV block. So why is this even interesting? Every other P wave is dropped, so you can't distinguish between Mobitz 1 and Mobitz 2, right? Because we said with Mobitz 1, we see the prolongation of our PR interval, where with Mobitz 2, we don't see that. There's just no way to really tell that with a 2-to-1 AV block. And for that reason, it could be an AV node fatigability issue, or it could be like a structural conduction issue with our like His-Purkinje system. So tricks to distinguish between Mobitz 1 and Mobitz 2 from a 2-to-1 AV block. So trying to increase our sympathetic drive, like doing exercise and getting like an exercise EKG stress test, if that block improves, then I would think that this is a Mobitz 1. But on the converse, if I try to increase my vagal tone by doing vagal maneuvers and then the block improves, that would push me more towards a Mobitz 2. And essentially, this is helpful to just differentiate as the management for Mobitz 1 and Mobitz 2 can differ.
Yeah, I mean that's extremely well said. I'll say that in terms of exercise EKG, you don't I mean, logistically, you don't necessarily need to put these people on the treadmill. Oftentimes, they're lying in 2-to-1 block on a stretcher, and you can just have them do like little scissor kicks of their legs when they're in bed. Usually, you don't do upper arm things because then you can't really interpret the EKG. But if they could do little kicks in bed and then just relax for a second, you can see if the conduction is improving or worsening. A lot of people don't like to do the second bullet point because you have someone whose heart rate is slow and then you're doing something else that's slower. So a lot of people are not comfortable with that, which I understand. But yes, if you decrease the number of P waves that you have, and you're actually when you have by increasing your vagal tone and your conduction improves, that actually means that the block may be below the AV node because what you're doing is you're just making things easier on that His-Purkinje system. You're sending fewer impulses, so you're allowing them to. You're giving that severely damaged His-Purkinje system more time to recover, so you're more likely to have conduction. Versus if you increase vagal tone in the AV node, it's sensitive to that vagal tone as well. So it falls asleep just like your sinus node does. But most of the time we do the first bullet because we're scared to slow people down more who are already slow.
Mhm. Okay. So this is our next EKG. Why don't you all pause the screen for a moment? Okay, so this is high-grade AV block. And essentially, so the red are the non-conducted P waves, and then the green is the conductive P wave here. And you can see that there's actually two P waves followed by a conducted P wave. And that's essentially kind of what would define high-grade AV block, meaning two or more non-conducted P waves. And what's happening here is that you have intermittent atrial conduction to the ventricles. This is higher risk for progression to complete heart block as well.
The only thing to think about this is make sure that you're in sinus rhythm because sometimes you can have atrial tachycardias or atrial flutters that look like this. And when there's an atrial tachycardia or atrial flutter, your AV node is designed to like not accept all those beats, and you can get almost a physiologic 3 or 4 to 1 block that's not necessarily heart block. This does more look like sinus rhythm where where there's a lot of P waves blocked, and this looks more pathologic than like an A tack or an A flutter.
Got it. Okay. One more EKG if you guys want to take a pause. Okay. So this is complete heart block. So these are all the P waves that I've highlighted here that I think I can see. And to me, I mean, the PP intervals look pretty consistent. And then I see these wide complex ventricular beats as well. So, and it doesn't really seem like there's any association between these P waves and this QRS complex. The PR intervals are quite different in between them. Our atrial rate is still like around, I think, 60, but our ventricular is around 27. So, in my mind, this is how I interpret complete heart block.
Hit on some really important points here. One is you put complete heart block as the read of the EKG, which is correct, but I would just make it a habit of saying what's going on in the atria and the ventricles. So this is you could say this is sinus rhythm with
Mhm.
like I know it sounds silly, but it's like sinus rhythm with a ventricular rate of like 55 to 60 beats a minute with complete heart block and a ventricular escape of like 25 or 30 beats a minute. And then the other point to determine whether this is complete or not, don't be fooled by like if you look at that second blue arrow and the second red arrow, you're like, oh, that PR looks like it could be a real PR. Like, well, why aren't those conducted? So you mentioned it, Sakshi, is that the PR intervals are none of them are consistent, which makes that less likely. Now, is there a remote possibility that just one of the P waves got through and one beat conducts and the rest of it's complete art block? Yes. I mean, it doesn't really matter clinically because this person's getting a pacemaker no matter what. But the way to determine if one of them's conducting is to measure the R interval or the distance between each of those red arrows. If the distance between each of those red arrows is exactly the same, then there's no P wave that's pulling in a red arrow closer. Because
Mhm.
if a P wave conducted, it would pull one red arrow a little bit closer into the other red arrow. But the fact that those red arrows all march out completely means that those blues and those reds are not talking to each other at all.
Got it. Okay. And essentially, that is what Dr. Matos and I were saying, that there's for no association between our Ps and our QRS. And we can often see wide complex because what happens is you have the supraventricular impulses that are not conducted to the ventricle, and then the ventricle is being now excited by an escape mechanism from like a junctional or a ventricular escape rhythm. Common causes. So can see progressive AV node fatigue, like Mobitz 1 during the acute phase of an inferior MI, but also like conduction failure, like infarct or idiopathic degeneration of our um, His-Purkinje system as well. And then medications, like discussed before, can also contribute to this.
Yeah, exactly. I mean, I'll just add two things. One, you talk about the location. I mean, this is why this escape rate is so slow, like I brought up in the beginning. Like the basal pacemaker rate of the sinoatrial node is higher than the AV node, which is higher than the bundle of His, which is higher than the bundle branch blocks. That's why when you get those wide escape complexes, they're so slow because the basal pacemaker of those cells is just slower. They just don't trigger as like spontaneously trigger as quickly. The second thing is that you'll you'll learn all this stuff and then you'll get totally confused by an EP note because they'll be like, oh, the complete heart block is vagal. And be like, wait a second. And so vagal can cause, and it's not on this list, and I'm not saying it's not, it's reasonable to keep it off this list, but it's always important when something goes in a heart block is to see what the sinus rate is or what the change in the sinus rate is. So if someone's in sinus rhythm or tachycardia with a rate of 80 to plus beats per minute and there's complete heart block, of course, that there's obviously pathology there in heart block. But if someone's heart rate suddenly slowed from 80 to 40 to 50 and they're in complete heart block, then it's a little odd that they're getting a slow sinus heart rate and heart block at the same time. And so you still can exclude some extrinsic cause in rare cases.
Got it. Okay. So next, I just wanted to briefly touch about what to do if someone has bradycardia. And this is assuming someone has a pulse. If they don't have a pulse, then you have to follow the ACLS algorithm for cardiac arrest. But if someone has a pulse, first, want to do our ABCs. If this patient is then stable, we can get an EKG because this might help us understanding what the underlying rhythm is. But again, if they're not stable, things that I think as being associated with not being stable, meaning like hypotension, they're altered. You can see signs of shock, heart failure, any type of like ischemic chest discomfort, anginal symptoms. That's something that you want to act a bit faster on. Things that we can try is atropine. And you would give that every like 3 to 5 minutes, the max dose being around 3 milligrams for that. Can also try transcutaneous pacing. So the pads from when you have your defibrillator, you can use them to actually pace as well. That can be painful for patients. So ideally, like if possible, trying to intubate and sedate them. But if you need to do it to save their life, you do. And then can also try a dopamine or epinephrine infusion as well. And then often these patients, once you're out of this acute phase, they will need a transvenous pacer to keep pacing them until they can get like a more permanent pacemaker placed.
Yeah, I don't have anything to add other than just to reemphasize what you said, which is awake transcutaneous pacing is like not great. It's like very traumatic. It's very uncomfortable. So you're either like very quickly moving toward a a temporary pacemaker wire through a right IJ, or providing sedation with low threshold to further sedate and possibly intubate them to make it more comfortable as you're moving forward. It's just a very uncomfortable endeavor, the awake transcutaneous pacing.
Okay, so I wanted to summarize the learning points here. Sinus bradycardia, we talked about that being a sinus node issue, a decreased sinus node activity. We talked about our first degree AV delay with a delay in the conduction from our sinus node to our ventricles. We also talked about second degree heart block. So we talked about Mobitz 1, 2-to-1 AV block, high grade. These are more AV node issues that can occur with AV node fatigability. And then we also talked about other types of second degree heart block, including Mobitz 2, 2-to-1, and high grade, again, where it's more of a bundle of His or His-Purkinje structural conduction issue. And then we also talked about our complete heart block, in which you're not having your supraventricular beats being conducted to your ventricles, and it's completely like asynchronous, essentially. And then one thing I wanted to highlight is that the Mobitz 1, Mobitz 2 fixed ratio, these are all a component of second degree heart blocks.
Your point is like saying secondary heart block just on its own is like not really that helpful, right? We need like a little bit more information because like this could be anything from Mobitz 1 to like this person's like a really healthy athletic person and there's absolutely nothing to do to like they need an urgent pacemaker. So trying to figure out, which one it is makes a huge difference in how they're being managed.
Got it. Okay. And then I just have some practice EKGs here. Okay, so we can just pause your screen. Okay. So this here is our Mobitz 1 Winke-Bach. We can see a dropped beat. And then when we look at our PR interval before and after the drop beat, the PR is longer before and shorter after. So that's why this is Mobitz 1. And I have one other practice EKG here if you guys want to take a pause. Okay. Okay, so this EKG is consistent with complete heart block. There is no association with the P waves in the QRS, and one way you can pick that up is by telling that the PR intervals vary between each one that you can see here. Our PP intervals, though, are consistent. Our atrial rate is around 100, and then our ventricular rate is around 15. So again, very concerning EKG here, but consistent with complete heart block. Okay, and that was it. These are my resources. Thank you guys for listening.